Hi, everyone. Thank you for joining today. My name is Beth Kohler. I'm the CEO of the Arizona Association of Health Plans, who are the state's private sector managed care Medicaid contractors. Today, we're going to be talking about potential federal Medicaid changes and their impact across Arizona. I was asked to join this. I'm a facilitator for the Flynn Brown Academy Health Day. I'm on the board of the Bioscience Roadmap Steering Committee, and I like to serve as everybody's Medicaid phone a friend here in the state of Arizona. So thrilled to have this opportunity to come talk to you today. Um, I think you probably heard the announcement when you joined, but this is going to be recorded. And if you have questions, the chat is disabled, but there is an opportunity for you to put those questions in the Q&A function here in the webinar. And I will see those and try my best to get them answered either throughout the presentation or at the close at the end. So with that, we'll go ahead and get started. And again, I want to thank you all for your interest in this topic and for joining today. And you may wonder, why are we here talking about potential federal Medicaid changes? And Congress is on the brink of potentially making the biggest changes to the Medicaid program in the program's history. Program started in the 60s. I'll talk a little bit about Arizona and its history with the Medicaid program. But what is on the table right now in Washington, D.C. constitutes some of the largest changes we've ever seen in the history of the program. And they will impact not only people who are enrolled in the Medicaid program here in Arizona, known as Access, but also all Arizonans, regardless of your insurance coverage or what you do for a living or how you interact with the healthcare system. So to get started, we want to do a little bit of an overview on what is Medicaid here in the state of Arizona. I know many of the participants here are deeply familiar with this program and have a long history with the program, but some people are not. And as we go around the state and talk about this, we learn that people don't understand what the program is. They confuse it with Medicare. So I'm going to give a little bit of a level set at the beginning. So Medicare, many of you know, is the federally administered healthcare program for our seniors and people with disabilities. Medicaid is the public health insurance program for low-income individuals and their families. It is jointly funded between the federal government and the state government. The federal government pays about 75% of costs of the Medicaid program here in Arizona, and that number varies by state. And the state government puts in about 25% of the costs. And we'll talk a little bit later about the ways the state government funds that 25% of the Medicaid program costs. And then each state administers its Medicaid program individually. So states under broad federal parameters are permitted to design programs that work best for their states. But Medicaid nationally covers about 1 in 5 Americans. It covers people of all demographics, and moms, babies, pregnant women, seniors, people with disabilities, and people who don't fit into any of those categories. Eligibility levels and benefits vary by state. I'll talk to you a little bit about who Arizona covers and for how long. And one thing that is often lost when we talk about the Medicaid program is it is the primary payer across the country for what are known as long-term services and supports or long-term care. So nursing facility care, as well as care in the home and the community that allow our seniors to age in place and avoid having to be placed into a nursing facility. So it's a very significant payer for those services. And any cuts that destabilize the program broadly will have an impact on our senior populations. So Arizona, of course, Arizona being Arizona, had to do it differently. And we did not actually join the Medicaid program until the early 80s. You may remember I said Medicaid started in the mid-60s. Arizona did its own thing, did not join the program until the 80s. And when it did, it created a unique structure that really relied on the private sector contractors to administer the plan. So you may remember I right now work for the collective association of the private sector contractors that administer access. But when that mechanism was put in place, it was wholly unique. No other state did it this way. Most states just use the government to pay providers directly. And over time, more and more states have moved into this same direction that Arizona took, recognizing its innovation and how it leads to higher quality and more cost-efficient care delivery. So here in Arizona, the Medicaid program is called the Arizona Healthcare Cost Containment System, or AHCCCS, as I'm sure you've heard. People across the state sometimes don't even know they're on Medicaid. They say, no, I'm on access. So, it may seem basic, but for those of you who don't live in this space, access is Arizona's Medicaid system. And access covers a wide range of needed healthcare services. It covers hospital stays, doctor visits, prescription drugs. I mentioned long-term care, and it is the primary payer for Arizona's public mental health system as well. So it really provides people enrolled in the program with the entirety of healthcare services that they might need. So you're going to hear a lot of rhetoric at the federal level of protecting Medicaid for people who deserve it, or able-bodied individuals shouldn't be on Medicaid. And I want to give a little bit of an overview of who Medicaid covers. So I mentioned when it was first established, Medicaid covered primarily moms, babies, and people with disabilities. And over time, additional populations have rolled into the program, including older children, including people who don't fit into those categories, but still have significant healthcare needs. Because, as you know, when people don't have health insurance, that doesn't mean they don't have healthcare needs. So those people were experiencing, people without health insurance who didn't fit in the Medicaid program when it was initially designed, still were getting sick, still were going to hospital emergency rooms, and we're getting inefficient, life-saving, and stabilizing care, but inefficiently because they weren't able to address their healthcare needs on the front end. So over time, Medicaid has evolved really into a broader safety net for people's healthcare needs. And when people talk about who deserves to be on Medicaid or who the program was designed for, I like to remind them that Arizona voters, in fact, decided 25 years ago who deserves to be on Medicaid and who should be on Medicaid. So 25 years ago, Arizona voters multiple times passed laws that said everybody with incomes below what the equivalent now is about $15,650 for a single individual. Everybody with incomes below that level is eligible for Medicaid. And so the state has covered those people since. Now, the Affordable Care Act offered states some financial incentives for the coverage of those same populations I just mentioned if they expanded slightly above that. And so Arizona did do that. It saved the state billions of dollars to do that. And so right now, all Arizona citizens with incomes up to $21,000 for a single individual are eligible for Medicaid. And you'll note I said Arizona citizens, because you may also hear, and there is a lot of rhetoric about Medicaid paying for people who are here who are not citizens. And here in Arizona, that simply doesn't happen. There are a few other states who have expanded their Medicaid programs using state dollars to people who don't have documentation that they are US citizens. That is not the case in Arizona. So when you hear Arizona policymakers talking about that, it's important to know who our program does or does not cover. There are a lot of numbers on this slide, but one of the things I wanted to convey was how broad of a reach this program has across our healthcare delivery infrastructure. So there are 2 million Arizonans on the program as of early 2025. And the state, using state and federal funds together, spends over $21 billion a year on this program. So those are dollars that flow out to our hospitals, our doctors, our dentists, over 100,000 providers registered and enrolled to serve people on the Medicaid program. So that is a lot of money going out into that healthcare infrastructure, supporting its availability for all Arizonans. So your doctor most likely is enrolled with Access and receives some sort of Access revenue. In other states, you have Medicaid waiting rooms, you have Medicaid-only providers. That isn't the case here because of our contracted managed care organizations that have a very, very wide network of providers for people who are enrolled in Medicaid. So as I mentioned, over 100,000 Arizona healthcare providers registered with Access. A couple of other notes: half of the babies born in this state are paid for by Access. And that number is surprising. It's surprising to me. It's surprising to a lot of people. And when we think about, though, what the income limits are, people, I think all of us would like for more Arizonans to have incomes that gave them access to commercial or employer-based coverage. I certainly would. But right now, these are the people that qualify for Access, and it's a really, really important funder of healthcare across our state. So, and I noticed this happened in an earlier presentation, but with a different slice of the pie, but I know this data, so it's not showing up for me some of the criteria, but this is showing you where Access spends its money. So the bulk of the money that Access spends goes to doctors and hospitals. You'll see 20% also goes to long-term care services, which we've mentioned a number of times, 13% to mental health. That other large slice of the pie, which isn't showing for me, I don't know if it's showing for you, is pharmaceuticals. So pharmaceuticals are, again, close to 12% of the Access spending. So again, as I mentioned, all of these providers that are out in the community serving members with commercial insurance or other payment source are also getting significant revenue from the Medicaid program. So what's going on at the federal level? Congress is attempting to extend the 2017 tax cuts and wants to find a way to pay for them. And so there is the one big beautiful bill, which if you've read any news source in the past few months, you've likely heard about that piece of legislation. And that is trying to extend the tax cuts, and as part of it, to help pay for those things and to reduce the budget impact of that extension, it's packaged with other spending provisions, including major reductions to social safety net programs. It is being hotly debated both in the House, which passed the bill a couple weeks ago, and now in the Senate, with opposition coming from both sides. And so congressional leaders are trying to find a way to thread a needle where they can get what they want in terms of these extensions, but also appease members on both sides of their parties. And so, for example, you have conservative members of Congress saying this bill doesn't reduce the deficit enough. In fact, even with the spending reductions that we're going to talk about in more detail, the bill will increase the deficit by 2.4 trillion over 10 years. So you've got members of Congress saying that's not enough. We want to fix this problem and we need further reductions in spending because we're committed to these tax cut reductions. On the other side, you've got more moderate Republicans and definitely members of the Democratic Party saying this bill cuts way too deeply and is going to have too big of a significant impact, too big of an impact on the healthcare infrastructure. There are many, many other non-healthcare provisions at play also that are impacting the debate. But you've got conservatives who want to cut deeper, and you've got moderates who are concerned about the impact that the reductions are going to have. So the committee, the Energy and Commerce, ENC committee that has jurisdiction over Medicaid, set itself a target of $880 billion in spending reductions. It exceeded that and came up with a proposal that will produce $1 trillion of spending reductions over the next 10 years. Of that $1 trillion in this one committee alone, the Medicaid savings are $800 billion over 10 years. So you've got tax cut extension, a lot of other moving pieces, Medicaid cuts of $800 billion over 10 years, and the bill as a whole still increases the deficit. So this is, this is happening in real time. I'm updating these slides every time I do a presentation because we've got a lot of different moving pieces at play federally, beyond just what's happening in Medicaid. So the Senate has set a target for itself of July 4th. That's highly optimistic, I think. But conversations are ongoing and we're getting updates every single day. I will talk a little bit more about how we and the healthcare community at large are engaged with our members of Congress, some of whom have been very important voices in forestalling further cuts and making sure whatever changes are made are workable for Arizona. So what do these reductions mean specifically in the healthcare space? The Congressional Budget Office estimates that the number of uninsured Americans will grow by almost 16 million over the next 10 years. And that includes changes to both the Medicaid program, which we'll talk about. It also includes changes to the Affordable Care Act marketplace, which you may know as healthcare.gov. And so what the bill doesn't include is any extension of additional subsidies for health insurance that is purchased through healthcare.gov, which previously had been heavily subsidized. So some of those subsidies are not continuing. And as a result, the Congressional Budget Office estimates that about 5 million people across the country will likely no longer access their health insurance through that mechanism. And then again, some of the changes we're going to talk about that will make it harder to get and retain Medicaid coverage will likely result in almost 11 million people losing their coverage through the direct provisions of the bill. So what does that mean for Arizona? So policymakers and policy wonks across the state are still analyzing, and new proposals are being thrown against the wall on a daily basis. But preliminary estimates from national groups indicate that these provisions will result in 200,000 to 350,000 more Arizonans without health insurance, and a $2 to $3 billion reduction in federal Medicaid spending in Arizona. And that's that 2 to 3 billion is an annual figure. And I'll talk a little bit more about why, but remember that because as we go through this conversation, we're going to talk about the economic impact that such a big reduction in healthcare spending will have across our state. Okay, so there are three main provisions I'm going to talk about that are in this bill that impact the Medicaid program. And I do want to highlight there are a lot of other Medicaid related provisions that I'm not going to cover either because they have a smaller impact, they're really administratively wonky, or they're going to impact programs in other states, but they're not really going to be a big deal here in Arizona. So I'm going to focus on the big three here in this state, and they are limits on provider taxes, limits on state-directed payments, and globally making it harder to get and retain Medicaid coverage. So let's start with provider taxes. What are they, and why does Congress care? So I mentioned earlier that states pay a portion of the Medicaid program. Here in Arizona, the state pays 25% of the program, and it uses a combination of state funding sources to do that. So the general fund, for those of you who pay any attention to the state budget, that is the big bucket of revenue the state has to pay its bills. So the general fund is a very significant source of state funding for the Medicaid program. About $2.5 billion in state general fund spending goes to Medicaid. The counties, before Arizona had a Medicaid program, the counties had significant responsibility for healthcare, and the counties still contribute to this day significant funds, hundreds of millions of dollars in funds to help support the Medicaid program. And then there's a mechanism that provides hundreds of millions of dollars as well and that is provider taxes. And how provider taxes work are that the state taxes healthcare providers. That tax money is used to draw down federal matching funds, and then the net payment is pushed out back into the healthcare delivery system, either to fund healthcare coverage, of which $700 million in provider taxes are used to do that, or to provide additional rate payments to healthcare providers like hospitals and nursing facilities. And so you may hear Congress talking about provider taxes as if they are some sort of fraudulent scheme. I've heard that term a lot. And I want to point out that this is a perfectly legal and widespread mechanism states use to fund their Medicaid program. 49 states, in fact. Alaska is the only state that doesn't have one form of a provider tax. There are heavy federal regulations around provider taxes. Excuse me. The state every year has to demonstrate that it complies with the statutory and regulatory framework around these taxes. So you may hear them described as fraud. They are certainly not fraud. Arizona is very transparent in how it gets and uses this money. But nonetheless, it's gotten a lot of scrutiny at the federal level about whether or not this is appropriate. And so Congress wants to make changes to how states use these monies to fund their Medicaid program. And they want to either allow states that are doing this currently to keep doing what they're doing, but just not grow the use of taxes and not add any new taxes if they're not currently using them. Or in the Senate, they want to roll back the ability of states to use these mechanisms. And so here in Arizona, right now, they want to basically cut the use of provider taxes in half. And what that would mean is the state would have to either find some other source, somewhere in the neighborhood of $1.5 to $2.5 billion a year. So find some other source to continue to keep making the payments that the state makes with these funds. And again, that's either for coverage for about 500,000 Arizonans or increased rates for hospitals, nursing facilities, and other providers. Or the state, if it doesn't have $1.5 to $2.5 billion, which, spoiler, it doesn't, it could raise new revenue, it could cut other programs, or it could roll back those programs, which is honestly the most likely course of action that the state would take. So that would mean that providers here in Arizona would see their payments reduced by, again, $1.5 to $2.5 billion a year, which would be a very, very significant hit to the providers here in this state. State-directed payments. So a sort of sister program to many of the provider tax programs is a mechanism that states use to make extra payments to providers in the Medicaid space. So you may have heard historically that Medicaid and Medicare don't pay providers their full cost. They don't cover the full cost of providing care to the people enrolled in their program. And that is true. And so states have used state-directed payments as a mechanism to make extra payments to providers to help stabilize their revenue and make up for the fact that Medicaid doesn't fully pay for the cost of care. Again, like provider taxes, heavily regulated. Approximately 40 states use them. And candidly, they are one of the fastest growing areas of the Medicaid program. It's a relatively new mechanism, only about a decade old, and 40 states have adopted them. So Congress right now, under federal regulation, states can pay providers up to about the average amount that commercial insurance pays for the same services. Congress wants to limit that amount to Medicare, what Medicare pays, which would be a big reduction from what commercial insurance pays. So again, having the same effect of limiting the amount that our healthcare providers can be paid from the Medicaid program, which just means limiting their revenue and significantly impacting their finances. So Arizona has a variety of state-directed payments. The biggest ones are for hospitals that are funded from a provider tax. So you've got a double whammy here for hospitals. And these new limits will reduce healthcare provider payments across the state. So the last item I wanted to focus on is eligibility changes. And the bills under consideration have a variety, make a variety of changes to the Medicaid program, all of which are designed to make it harder for people to access and retain their Medicaid coverage. So I'm going to talk about a couple of those. The first, and the one you might have heard the most about, is requiring certain Medicaid enrollees to prove they're working before they enroll in Medicaid. So you make Medicaid work requirements. These have been a buzzword for more than a decade. Arizona has had a statutory requirement to seek approval to allow for Medicaid work requirements for more than a decade, and it's never been implemented here. It has been implemented in a number of other states across the country. And what you see in those states, and I'll talk a little bit more about why, is invariably you just see massive drops in people enrolled in the program. So let's talk about work requirements a little bit. I think all of us see huge value in work. And I certainly do, at least. I guess I can't speak for the rest of you, but most people see huge value in work. And when Congress talks about subjecting able-bodied Medicaid residents to work requirements, it's very, very popular, politically and in the public. But I think the way that it's being done, I think it's important for everybody to understand that, you know, when they say able-bodied, and you may hear this rhetoric down at the state legislature as well, there are some bills being discussed to limit coverage for able-bodied Arizonans. What they're really talking about is a certain demographic of people who do not qualify for Medicaid because they don't have a formal federal determination of disability. They're not pregnant, they're not a parent of a young child, and they are not a senior. So everybody else falls into this bucket that's being framed as able-bodied. You may hear, if you've been in this space a long time in Arizona, they're rhetorically called childless adults, not meaning you never had a child, meaning you're not currently caring for a young child. So I want to talk a little bit briefly, though, about who's in this population, because I think it's really key to whether or not some of these Medicaid work requirements work. So in this population include a large number of our members with serious mental illness. This population spans the age range. You'll hear some of our members of Congress say it's a bunch of 22-year-old kids playing video games on their parents' couch. But I'm going to give you a link for some data that demonstrates there are people of all ages between 19 and 64, and it's pretty evenly spread across those ages. You have a lot of pre-Medicare individuals who have disabilities, but perhaps don't have that formal federal designation. You have almost half, 45% of the people in this population group are female. You've got a large number of people being treated, tens of thousands of people being treated for substance use disorder and opioid use disorder. You've got about, I think, 1,700 people who are getting ongoing care related to having an organ transplant. So you have people with really, really complex health conditions who are in this group who, without this health insurance coverage, will have continue to have significant healthcare needs that they won't have a payer source for. They will end up at hospitals, and that hospital will have to provide stabilizing care. But, when you talk to conservative economists, they openly acknowledge that this isn't like SNAP or TANF, where members get, a specific dollar amount associated with their benefits. This is health insurance coverage, paying the providers who provide care. And this, when people lose coverage and they still get sick and they have to go to the hospital for uncompensated health care, it's a pretty inefficient mechanism to deliver health care to our population. So there will be, very likely, when you build extensive bureaucracy and make people regularly prove their eligibility for health insurance and that they are working, invariably people will fall off the program. We just know this is the case. We want to make it as easy as possible. It is still a big barrier. People lose coverage. And a large portion of that 11 million people that the Congressional Budget Office estimates are going to lose coverage as a result of this bill are people who won't file the paperwork or can't navigate the bureaucracy that's created to document that they either should be exempt from these requirements because they have a significant healthcare need, or that they're working and compliant and just can't get the paperwork in on time. And so I think that we see that in other states that have implemented this, it has cost tens of millions of dollars, if not close to $100 million, and with significant coverage drop off and significant number of people not complying. So I expect that's what we'll see here in the state. And then again, we go back to who is the impact on, and I'm going to show you some data, but it ends up being on our providers who still have to provide uncompensated care when people still get sick. Other provisions that are making it harder to get and retain Medicaid coverage are checking eligibility. Right now, Medicaid eligibility is checked once a year. The provisions will require states to check it every 6 months. It will repeal some rules from the prior administration that was designed to make it easier for people to get on the program and require additional eligibility data checks. So all of those collectively are designed to make it a little more difficult for people to get and retain Medicaid. I mentioned Arizona has some statutes around work requirements. So either way, regardless of what Congress does on the work requirements, Arizona is likely to have a work requirement under the Trump administration. So the state is required to ask permission from the federal government, which they can grant even if this bill doesn't pass. However, the Arizona law is a little more flexible in terms of how that work requirement is designed. Arizona has done extensive stakeholdering about who should be in and who should be out, and they've developed a proposal that will pause enrollment for noncompliance, but will not result in people completely losing their Medicaid. That request to implement that program was submitted back in March. The federal government is considering it, but then Congress may layer over those requirements these additional federal mandates on work requirements. I will state, though, that Arizona statutes require that these people prove their ongoing compliance with work requirements monthly. That is a significant departure from what Congress is considering. So other states that have implemented this started monthly and quickly realized how unworkable that was administratively. Again, big bureaucracy, hundreds of millions of dollars in new government costs and new government workers. So they've rolled that back, for example, in Georgia, to once a year, and Congress is really looking at a once a year verification, once or twice a year verification of this. Arizona statute requires monthly. So that is a big difference and will have a very significant impact here in Arizona about people's ability to comply. So we'll see how that interfaces with whatever comes out at the federal level. What wasn't included? So there were a number of changes that the federal government was going to make in how they pay for Medicaid across the country. So I mentioned the feds pay 75%, the state pays 25%. That's actually an average figure, and some populations the feds pay more, some populations the feds pay less. So the federal government was talking about monkeying around with the percentage that they paid, and that would have been a massive cost shift to the state of Arizona to the tune of billions and billions of dollars that the state would have had to find to backfill that federal cost shift. That thankfully, through the advocacy of Congressman Ciscomani and many other states who would have had that same impact, that is off the table. The feds were also going to change Medicaid from being an open-ended federal flow of money to a capped federal flow of money. That's also, again, big cost shift to the state, also off the table. And then the last one I wanted to mention is, again, we hear from policymakers time and time again about the fraud, waste, and abuse in the Medicaid program. And anybody working in this space is, very, very committed, at least my experience has been, to making sure they do everything to prevent and detect fraud in the healthcare system. Like any large system, whether it be banking, real estate, Medicaid is subject to bad actors constantly trying to exploit it and make money off it. We saw some horrific examples of that with the state-run portion of the Medicaid program a few years ago. And so I think there is a lot of rightful attention on making sure this program, that we do all we can to make sure there's not fraud, waste, abuse, and member exploitation in the program. That said, the rhetoric on fraud, waste, and abuse that's happening in Congress and the changes that are being pegged as addressing fraud, waste, and abuse really don't get at the heart of that problem. So I put up in here, there's not real fraud, waste, and abuse changes included in this bill. So those things were not included. But again, as Congress goes back and forth about how to get sufficient votes to pass something, all of us are watching to make sure some of the really, really significant federal cost shifts don't find their way back into the bill. So I talked a lot about what I think is going to happen if some of these changes are made. And I want to highlight that the reason we know what will happen very likely when hundreds of thousands of people lose coverage is because Arizona did this. During the Great Recession, at a time of much bigger budget stress than we're currently experiencing in our state right now, Arizona froze enrollment into its Medicaid program in that same population that we talked about, the childless adults. And you can see this graph, which was prepared by the Hospital Association back years ago, that showed the red line is childless adult coverage in the program, and you can see that drop precipitously when the enrollment freeze was implemented. And you can see the direct inverse relationship between that enrollment and hospital uncompensated care. And so during the Great Recession, when those very difficult decisions had to be made, hospital uncompensated care went through the roof as a result of fewer people having health insurance coverage. And hospitals white-knuckled it through the recession. They shifted costs to private payers like small businesses and other employers who were purchasing commercial insurance for their employees. And this cost shift, you may have heard of the hidden healthcare tax, is a main reason why Arizona's business community has really galvanized behind supporting Medicaid for over the past 2 decades. And because they saw what happened, we have real data. We know that people just don't go find insurance elsewhere because many of them have no access to employer-based insurance or cannot afford it. And we know that they still get sick, still go to the hospitals, and the hospitals have to bear the brunt of providing that uncompensated care. And so when the opportunity came to remove that freeze with the Affordable Care Act and the corresponding financing associated with it, Governor Jan Brewer exhibited great leadership, I think, in leading a statewide campaign backed by healthcare providers, advocates, and the business community to restore that coverage. And you can see what happened where hospital uncompensated care will never be zero, but it's stabilized greatly as a result. So why should we all care? I think hopefully I've drawn some connections about how major changes in the access system destabilizes the entire healthcare sector. As I mentioned, providers who deliver healthcare to access members also deliver healthcare to all of us. If those providers are not able to financially sustain themselves and they have to stop providing specific services or they close service locations in rural Arizona, for example, all Arizonans will not be able to access the needed care from those providers. And that has a big impact across Arizona's economy. And that impacts our state's broader economic competitiveness when we have those job losses. I'm going to talk to you a little bit about what that's going to look like. But first, I'll mention Arizonans for Better Healthcare is a collaborative effort between the Access Health Plans and a variety of healthcare provider organizations like 2 hospital associations, the mental health providers, doctors, etc. And so we are all working collaboratively to provide education across the state and make sure members of Congress understand these very real impacts that the state will face. And part of that collaborative effort was we worked with the Arizona Chamber of Commerce Foundation to fund an economic impact analysis that looked at, we don't know exactly what Congress is going to do, but let's run some scenarios of what the job loss and economic impact will be if we reduce Medicaid spending and healthcare spending across the state. And so I don't expect you to read this detailed slide right now, but I want to present some of the flavor of what is in this report, and you'll have a link at the end of the presentation that will allow you to access the full report. But for example, Arizona's healthcare industry is a very, very critical sector in our state's economy, and it is one of the sectors that has been strong through recessions and through COVID. And there are almost 500,000 healthcare jobs here in the state of Arizona, producing $38 billion in state GDP. So when the economists looked at what would happen if there was a 10% decline in that industry, they estimated almost or slightly more than 100,000 FTE job losses across the state. And that's beyond just doctors and nurses that you would expect to be impacted. But when those jobs go away, that has a ripple effect across the entire economy, resulting in significantly more job losses. And they estimated $17 billion in lost economic activity just from a 10% decline in the healthcare industry. So we've got a couple of other scenarios here. I think you can see that the bottom line is very, very significant job losses, close to the equivalent of the Great Recession in some cases, and significant losses in economic activity. And so the economists who prepared this report indicated that, even though we don't know exactly what's going to happen, impacts of this magnitude would have negative repercussions, equating to a Great Recession, and would offset much of the economic growth that policymakers here in Arizona have been focused on for the past decade in terms of economic development programs and revenue realignment. So there is a lot at stake here as Congress considers how it balances its own fiscal budget, but pushes much of the impacts down here to the state. This isn't Medicaid related, but I'm throwing it in anyway because I think it's really important, and I don't think it has gotten as much discussion as I would have expected. So, like cost shifting from the federal government to the states on Medicaid, the bill under consideration also increases state cost for SNAP program, formerly known as food stamps. And right now the estimates are the state will have to find 500 to 600 million in state funds for SNAP, or the entire program is at risk. And so 850,000 people, families and children in the state, rely on SNAP for food security. And there is a very, very significant risk about the existence of this program at all if the state cannot fund these programs. And this is one you're seeing right now in Congress where they're debating procedurally, very technical procedure decisions. Can this go in the bill? Can this go out of the bill? Yesterday or earlier this week, the Senate parliamentarian said this can't be in the bill. Then there's a notion that maybe they fixed it so it can be in the bill. So this one is still, I think, back and forth whether this will happen. But if it does, it's massively significant. And again, isn't getting the same kind of attention that the Medicaid changes are getting. So I did want to call attention to it. All right, so we've got a couple of links here for you. On the left is that economic impact report that I mentioned. The middle is the website for the Arizonans for Better Healthcare. We're trying to get anybody who wants to be connected with their member of Congress to talk about how all of this makes them feel. We're trying to facilitate the ability for people to do that. And then on the right is some access data that they have published about the potential impact. It's broken out by congressional district, by county, by population. There is a whole host of information out there available for people who want to learn more. And if you want to learn more and you can't navigate any of these things, you can just reach out to me directly via the email that's there. And I see one question. I've only seen one question really throughout this whole thing. And I see Matt Jewett is asking, is the 500 million SNAP administrative cost shift per year? Yes. To my knowledge, I've talked directly to the director of the Department of Economic Security, and that is what he has indicated to me. Yes. And that the entire program's at risk if the state can't put up those funds. Shocking, I know. So with that concludes my direct presentation, but again, I'd be happy to answer any questions from the group at all. Okay, seeing none, I'm glad this was so informative that all of your questions were answered. I'll turn it back over. Oh, what keeps me up at night? I think that is a good question. And I have been doing this for a very long time and have implemented a lot of changes to this program. And I will tell you, I truly believe that once people see the impact of these reductions, we will see a pivot in, we will see a pivot in how our policymakers respond to them. But I am concerned about the ability for states across the country to build this infrastructure to mitigate and make implement these changes in a way that is least harmful for members and providers. So all of this keeps me up at, this is all I do basically, is talk about this and work on access related issues. But, the ability for states to build an infrastructure that's workable, all 50 states across the country in the next year is going to be really difficult. And obviously, I've lived through significant healthcare coverage reductions in the past, and that was a very scary time, and I hope that we don't end up back there. So solutions, I see a couple questions on solutions and advocates. I think it's really important that if you feel strongly about this, that you make your voice heard to policymakers in this state. I mentioned Congressman Ciscomani has been incredibly engaged and a really important voice trying to help articulate to members of Republican leadership in the House and now also in the Senate to not shift costs and do significant damage to healthcare and people in the state of Arizona. But all of our congressional members should hear about what you think as voters are important to you. It's really important that they understand your priorities and what you think about some of these changes. And so we're encouraging everybody to advocate. They are hearing those voices, I think. And so I think there's a lot people can do to take action by contacting their members of Congress with that message. And again, Arizonans for Better Healthcare can help be a voice for that. In the version of the state budget negotiated between the governor and the Senate, is there funding for the SNAP shift and potential Medicaid cuts? So at this point, no, you do not have funding being put into the budget because of the uncertainty. None of these things have passed yet, but there is discussion and recognition that the state will have to take some action at some point to fund some of these things. Although again, the numbers are so big that, it's not like there's a big extra pot of revenue sitting around there. And the governor has said the state doesn't have revenue to backfill some of these cuts. Interestingly, the House budget, one of several House budgets that passed, did take a pretty big Medicaid cut. And there are some House Republican members calling for additional cuts to Medicaid to get ahead of these cuts. I haven't followed the logic quite on that one yet, but so nothing on this is included in the state budget at this point. What would be the official date or an idea of when these changes happen if passed? That is a good question. The work requirement deadline in the Senate is December 2026. state Medicaid directors across the country are advocating for an extension to that. It's just not simply possible to build the enormous state government infrastructure in that time. The provider reduction changes are also uncertain, but over the next few years. Are we seeing a shift back towards services being provided outside of traditional medical or insurance-based systems? I mean, there are doctors, well, I'm not sure what we mean outside of traditional medical insurance-based systems. There are concierge doctors who are taking direct payments and not going through insurance. If that is what is meant by that, I'm not clear. If not, maybe put a little additional clarification in the question, and I can try to be more specific. What are the odds of the Senate concluding their work by the end of next week? I wish I could tell you. I truly don't know. I think there is a lot of moving pieces, and as I tried to convey, a lot of competing priorities that they're trying to work. Although we have a very, very influential president who wants to get things done, and so I think it will be interesting to see how he brings that influence to bear on members of Congress. Do you have ideas, and I'm sorry, I'm trying to read these quick because now they're flowing a lot. Do you have ideas for rural areas who could proactively start exploring in the case of lost jobs and sites? So I will say, and I don't know if you're asking for economic ideas or hospital related issues, but the Arizona Hospital and Healthcare Association is actively thinking about support they can offer their rural healthcare members to prepare for some of these changes and to identify, I think, options for the state in terms of how it can find funding for these areas. I think a lot of these conversations are in their infancy, and hopefully they don't have to get to that level, but I know there are a lot of conversations happening, and ASHA representing rural hospitals is in the center of some of those. How do I recommend getting this information out at the local or municipal level? That is a great question. So I and many of the people working on these issues are more than happy to come talk to you about this, share this information. We are doing presentations all across the state to have these conversations, and I would be happy to connect with you offline about opportunities. Do you envision healthcare systems like Banner and Dignity going out of business or consolidating? I can't specifically say what any individual healthcare system will do. Those are very large integrated health systems that will have to take a look at their own revenue impact and make business decisions. I haven't heard any of them say they're going out of business. I don't want to leave anybody with the impression that Banner Healthcare is going out of business, but I think they're all looking at what are the revenue changes that these proposals might bring, and how would they as a business respond to those. And that might look different in different areas of the state. Banner has business in rural areas and in central Phoenix, and they're going to have to think about the changes they need to make to keep their business financially healthy if significant Medicaid revenue goes away. Are there any initiatives to help people formally document their disability before this would be implemented? That is a great question that I don't have an answer to, but I know there are a lot of community partners working extensively to look at issues that would help support people either go that route or figure out how to document what they need to document to keep their Medicaid coverage. How can the intent of the original effort be achieved while mitigating the risk outlined in the presentation? And I assume that question is, how can Congress get what it wants without harming? And if I had the answer to that question, it would be done. I don't, unfortunately. That is what Congress is trying to work through now. Those of us who are working on the healthcare side of the house are trying to support the information they get about these specific impacts, but I don't have an X plus Y equals Z solution for what they're trying to solve for. Our advocacy efforts engaging private insurance and farm business to speak for the healthcare industry. So we are in regular contact with our friends in the commercial health side of the house nationally, America's health insurance plans, or programs and commercial insurance is deeply engaged in these conversations, and farm businesses, pharmaceutical companies are also doing a lot of advocacy at the federal level as well. So thank you all for your interest. That was a lot of really good questions. I'm sorry I don't have clear answers for all of them, but again, feel free to reach out to me if you want further discussion on this or if you need additional information. Do you think that the cuts could lead to a wholesale discussion or rethinking of healthcare access to a right versus a privilege? I mean, that's an evergreen conversation that I think is happening as we speak. But I mean, I want big healthcare policy decisions. I can't say whether these are will not, but I think if billions of dollars come out of state or trillions nationally of our healthcare industry, it will cause a wholesale reckoning on a lot of different areas. So someone asked for the QR codes. There they are. And our Flynn folks, I don't see any more coming through. So. All right. Thank you, everyone.